Hello and welcome back to another MDC question style walkthrough. If you are new to these sessions, what we do is we take a question from the MDC recall question bank and we walk through it together. I'm Dr. Iken Skuzi and I'll be taking you through today's session. So today's question says a 52-year-old woman being managed for breast cancer presents to the emergency department with shortness of breath, and a chest x-ray is shown below. So this is a chest x-ray, and the question is, what is the most likely diagnosis? A, acute left ventricular failure. B, hemothorax. C, lung cancer. D, pleural effusion. And E, pneumonia. So, we are going to go through the stem of the question, pick up the salient points, and then we'll try to read the x-rays of the x-ray image, put the findings together, and come back to try and see if we can make the diagnosis. So the stem of the question, let's see which points here are relevant. 52-year-old woman, well, she's almost elderly, and we are told she has breast cancer and presents to the emergency department. So this is some acute presentation, and the presentation is that she had shortness of breath. So the salient points here that is breast cancer, which is a relevant past medical history, or current medical history, which is so high. So and then the shortness of breath. So we'll outline that. So breast cancer and shortness of breath representation relevant. But that is about it. And now let's see if we can read the x-rays of. So this is the x-ray we've been given. This is the image of the x-ray. And as always, there are so many algorithms out there for reading chest x-ray, but you should stick to one that works for you. The one I typically use is the A, B, C, D, E, F, G, and I. This is I find it to be simple and easy to remember. So if that works for you, you can use that, but there are other algorithms out there to help you read the chest x-ray in a more systematic way. The reason for this is that it allows you to pick up all the salient findings in an x-ray without getting distracted by the obvious. So you follow that algorithm, you don't miss it, you follow it one letter after the other and try to read it in a more systematic way. That way, even when there are obvious lesions that are distracting and calling for your attention, you still are able to pick up all the other lesions that might be present in the image. So let's use the ABCD algorithm, which is what I use and I believe is simple. So A, B, C, D, E, F, G, and I. So A here is airway. A stands for airway. So the airway that we are looking for is the trachea, and that is what is visible on a chest x-ray. And so when you take this chest x-ray, for instance, the trachea is this radiolucent structure in the center, extended from the neck in the center, extended so from the chest and then the neck, and extending down to the middle of the chest over there, and then it gets to this junction. It kind of branches there. You are looking at these radiolucent areas there, right? And then it kind of goes down there, and that is the branching, the bifurcation of the trachea into the right main bronchus, which kind of continues more directly with the trachea, and you have your left main bronchus, which branches more acutely off at the carina there. So you are looking at that, and what you want to look for is it angulated in a way? Is there any obvious lesions or angulations in the trachea? The only way to tell if there's an angulation is to draw a straight line down the spinous process of the vertebrae, and the spinous process of the vertebrae are these radiopaque lesion, these radiopaque structures in the middle. So you draw the straight line down the spine over the body of these structures. Down this line is not very straight, so, but yeah, you have that straight line down there, but you realize that the trachea kind of veers up to the right a little. So there's some form of trachea deviation to the right, and the reason there's a trachea deviation to the right could be that there is something on the left. There's something on the right that is pulling it towards there. So there's a pull factor, or something is on the left that is pushing it away from it. We'll get to know that once we go through this whole algorithm. but we've noted that there's a tracheal shift to the right, and that is your A. So airway. Then you are looking for B. B is for bones. So the main bones that are visible and that you can obviously see on the chest X-ray are your clavicle. So your clavicle up here, and this is your left and right clavicle, right? So you look for the contour of the clavicle right from the medial margin or the medial border where it articulates with the sternum all the way to the lateral side, and you trace the entire contour all the way out, looking for any breakage in the contour of the bone that might suggest clavicular fractures. And in this case, the clavicle looks fine. You look at the bones as well, the ribs as well. So you're looking at both the anterior and the posterior ribs, try to trace them, trace their roots all the way to the back. And most of the times, most of the rib fractures tend to occur at the angle, because that is where most of the tension, if there's any trauma, is usually transferred. And that's where most of the fractures tend to occur. So you try to trace the contour of each rib, from this anterior joint where it articulates with the sternum all the way to the posterior side where it articulates with the spine, the vertebrae. So you are trying to look for any fractures that might be there. And as I said, most of the fractures tend to occur at the angle, but they can occur anywhere else. So try to look for any bony defect that might be present. And that is for B. And in this case, there seems to be no obvious bony lesions. B, also still on the B, you are also looking at the spine too as well. There might be obvious spine defects like scoliosis, which can be visible on the AP or PA view of the chest X-ray, which will be seen as a lateral deviation of the spine. But in this case, we are not seeing any of that. So there seems to be no obvious bony lesion. C is cardiac. So cardiac shadow. So C for cardiac shadow, you're looking at the shadow of the heart or the cardiac silhouette. So you're looking at the margin of the heart. So let me use a different color there. So you're looking at the margin of the heart. So this is the border. So this is the right border, and then this goes up there, the superior border formed by the aortic arch there. But we can't see much of the heart after that. The left margin is completely obscured by whatever lesion this is. And so what you can say is that we can comment on the right margin, which we know the right margin of the heart is formed by mostly the right ventricle. The superior part of it here is formed by your superior vena cava, so SVC as it comes into the right atrium. Then the lower margin here is formed by your IVC as it goes into the right atrium. But yeah, typically most of the part of the right margin is formed by your right ventricle. So we can't really comment much on the cardiac silhouette, aside the fact that we can see the right margin, but we can't see anything else after that. So because of that, you can't really comment on the cardiac thoracic ratio. So when you're reporting this in exams, you have to clearly state that you can't comment on the cardiac thoracic ratio, because they will be expecting you in an X-ray where you can visibly see the heart. They will be expecting you to comment on that, which is what happens when you get to the C. But in this case, you can't. So you have to state to them. So it's an important thing you can regard it as an important negative. You have to state that. Let the examiner know that, okay, you were looking to do that, but you couldn't do it because of that. Right. So that is that. D, so that's for C. Then D is the diaphragm. So the diaphragm, you're looking at both the right and the left hemidiaphragm. In this case, the left hemidiaphragm is also completely obscured by whatever lesion this is, but typically the right hemidiaphragm is always slightly higher than the left because of the liver on the right. When you're looking at the diaphragm, you're looking at the contour of the diaphragm. Is it unusually higher than expected, which you might see in some patients who have, let's say, atelectasis. So when there's a collapse of the lungs, you have this compensatory elevation of the diaphragm at that side. Or is the contour not smooth as expected? In a case of somebody with diaphragmatic rupture in some trauma cases, you might find that. or is it flattened? It's flattened than usual. So for somebody with some obstructive lung disease like COPD, um, you have that there's hyperinflation of the lung, so you have the diaphragm seems to be flattened than usual. But these are all things that you can pick up in these specific conditions. So, but here in this case, the right diaphragm, hemidiaphragm that we can see, the contour seems to be well outlined and it looks normal. We can't comment on the left because we can't see it. You don't comment on things you can't see. E, so that's for D. E is for effusion. So effusion here is are there any fluids? And fluids are best appreciated at the costophrenic margins or angles of the image. So you are looking for any evidence of fluid. So your costophrenic margin angle there, your cardiophrenic angle there seems to be a little bit of blunting on the right costophrenic and then the right cardiophrenic margin. Over here is completely lost and you have this meniscus sign over there. So there's obvious fluid on the left and you have this homogeneous opacification here and there's a meniscus there. And then you have this blunting here too as well. So that is for E. F is for lung fill. So you're looking at the lung fills, the markings of the lungs. You should see some vessels, some vascular markings in the lungs, in a well aerated lungs or a well ventilated lungs. You should see that, and it shouldn't be completely radiolucent because there should be some whitish areas because there are lungs markings there and there's vasculature there too as well. So that you should see that throughout the entire lung field. But when you see an obviously either hypolucent or an obviously radiolucent area devoid of lung markings, you could that in some cases, for instance in pneumothorax, you see that because the lung is completely lost in that area and it's just an empty space. So you see radiolucent, completely hypolucent areas there. And you might also see in the case of lesions which are radiopaque, so you see opacifications in that area. And in this case, we are seeing that there's an obvious loss from this whole area. We can't see the lung marking and it's just this homogeneous opacification, and this is occupying both the middle and the lower lung zones of the left hemithorax. So that is for E. That is for F. So if lung fills, then G is for great vessels. So great vessels, we are looking at the aorta, so the aorta and the pulmonary branch, the bronchopulmonary branch. So you're looking at, and that typically, so you have your pulmonary arteries, your main pulmonary vessels there, and then you have your aorta, which is what is marked in the yellow there, and then you have between those two structures you have the aorticopulmonary window, and that is that space in between those two structures. And typically what you find in that window is lymph nodes, and of course there are some nerves there too as well, and your vessels. So when there's some form of lymphadenopathy, that area might be filled up and the window there is usually lost. Somebody with mediastinal lesions as well, so mediastinal enlargement, so either because of a lymphadenopathy or somebody with a thymoma, for instance, in that area might also be filled up. Aortic root aneurysms, for instance, that area too might look enlarged, so you have this mediastinal widening and the aorticopulmonary window is completely lost and all of that. But yeah, so G is for great vessels. Then I is your impression, where you put everything together. So in this case, we've seen that there's the positive findings are that there's a tracheal shift to the right and there's homogeneous opacification on the left hemithorax, occupying both the right, both the left and the middle lung zones, and there's a positive meniscus sign. We also have some small amount of fluid on the right, evident by the blunting of the costophrenic angle and the cardiophrenic angle there. So those are the findings all put together from this X-ray. So now let's go back to our question and see how we can put the findings of the X-ray and that of the clinical features of the patient together to make a diagnosis. So we were told that patient is a breast cancer patient and he has shortness of breath. And from our findings of the X-ray, we said there is fluid on the right, very small amount of fluid on the right, but quite a lot of fluid on the left, and much of the left lung is gone because the lower and then the middle zones of the lung is completely occupied by fluid. So it means that part of that left lung is completely pushed and collapsed by the fluid. And that could explain why this patient is having the shortness of breath. So the most likely diagnosis in this case, let's try to rule out the ones that we think is not are wrong, and then try to see what is left and decide on which is the best answer. So we can rule out pneumonia, and we don't have any clinical evidence in terms of clinical features or clinical symptoms of the patient. They would have probably been told he has cough and probably fever and some other signs as well. We don't have that. And from our x-ray, we have seen a homogeneous opacification. You can see opacification in pneumonia, but in this case, the opacification has a minuscule sign, and that suggests fluid. In pneumonia, you can also have parapneumonic effusion, but it won't be this massive on just one side, as we are seeing in this case. So you might see some parapneumonic effusion as well, but it is unlikely to be in this case. Lung cancer, you probably see a lesion, a mass. We don't see that here. But of course, you can't say it's never so, because for all you know, there's a mass inside, there's homogeneous opacification, but we can't see that, so we can't say this person has that. So we can rule that out as well. And as I said, this homogeneous opacification has a minuscule sign, and that suggests suggestive of fluid. So we'll be leaning towards something that has fluid, mainly fluid. Acute left ventricular failure. We'll also cross that out, because in left ventricular failure, whether it's acute or chronic, we will tend to have a bilateral heart failure. Will tend to present with bilateral pleural effusion, even though sometimes you have that the effusion is massive or is more on one side than the other. But in this case, it seems to be obviously effusion more on the left and just a very small amount on the right. But again, in heart failure, mostly the fluid is more on the right than on the left. But in that case, you can have more fluid on one side than the other. But in this patient's chest X-ray, it seems to be more obviously a fluid on the left than any other part of the chest. So we also rule that out. It's not completely wrong, but the symptoms here don't suggest. We have not also been given any history suggestive of chronic cardiac condition that might suggest that. We've been told the person is a cancer patient. Well, somebody who has cancer could be on chemotherapy agents, and these could be cardiotoxic and cause heart failure and all of that. But that is a fast stretch. So we'll also rule that out. Remember, the diagnosis is most likely diagnosis and not differential diagnosis. So that is not a very most likely diagnosis here. So we'll rule that out. Now that leaves us with hemothorax and pleural effusion. Now, hemothorax is blood in the thoracic space, and blood is fluid, and it will have similar appearance as we are seeing in the chest X-ray with any other fluid. So in this patient, we are kind of torn between pleural effusion and hemothorax. But hemothorax, typically there is always an evidence of some trauma. Something must have disrupted a blood vessel to cause the blood bleeding into the thoracic space. We haven't been given any evidence of trauma. So if this patient came in after a road traffic accident, then we'll be more leaning towards that. But this is a patient we've been told has some chronic condition going on. We haven't been told any history of trauma in the stem of the question. So we'll kind of put an asterisk to that, but that won't be our most likely diagnosis. If you are going to arrange them in terms of which one is more likely, maybe it will be high up there, but I don't think that should be the most likely diagnosis. So hemothorax will also be ruled out, and that leaves pleural effusion. So this is massive left pleural effusion. So if you are going to arrange these options in terms of which is more likely, so pleural effusion, the correct answer, then followed by hemothorax, then you can add left ventricular failure, then you follow by pneumonia, hopefully with the reason that there's parapneumonic effusion, and then your lung cancer will be the least likely. But so the correct answer here is massive left pleural effusion. So let's recap the findings of the X-ray and the algorithm that I just mentioned. This is the X-ray with your annotations of the findings that we already discussed. Trachea looks a little bit shifted to the right over there. So you see there's the shifting of the trachea over there. Then you have this dotted white line there is your meniscus. Green overlay is your homogeneous opacification, suggestive of your fluid with your meniscus sign. And then you have your small pleural effusion on the right there too, shown by the red overlay. So that is about it for the findings. And then the algorithm I mentioned was A for airway, which is the trachea that we've discussed. Bones, B for bones, which is your clavicle, ribs, scapula sometimes is visible. You can see that in your vertebrae. C for cardiac silhouette. You look for the right and left margin. You comment on the cardiothoracic ratio if you can obviously see the margins of the heart. If you can't, you state that you can't, and you give the reason why you can't. The diaphragm, you're looking at the contour of the diaphragm, looking for lesions that might suggest like diaphragmatic rupture or eventration of the diaphragm or flattening of the diaphragm. All of these have clinical implications, which I've discussed some already. E for effusions, which you've seen here in this case. F for the lung fields and fissures. So you're looking for any obvious lesions in the lung fields and see if the lung fields extend all the way through the entire chest, or there are areas where the lung field is completely lost. In this case, somebody who has pneumothorax, for instance, or the lung field is taken over by something else, in this case, fluid. G for your great vessels. So you talk about your aorta, aortic arch, your bronchopulmonary vessels, and your aorticopulmonary window. Comment on that, and we have discussed some of the relevant of all these structures. Then I is your impression. You put together your findings. So in this case, we said the patient has massive left pleural effusion with deviation of the trachea or with right trachea shift. You can also add, of course, there's some small evidence. There's evidence of small pleural effusion in the left as well, the right as well, but that's not very clinically relevant in this patient. So, recap of some of the clinical features of pleural effusion. We've already been told that we've already been told a few. We have shortness of breath, so dyspnea, and the dyspnea is usually because the lung field, as we said, is completely taken over by the fluid and the lung is compressed. And in this case, we can see the entire left lung was gone. The left and lower zone of the hemithorax we've seen that was occupied by fluid, so it means that a large proportion of the lung has been collapsed on the left side. So that is present with your dyspnea, and that can lead to hypoxia. You may have varied chest pain in some patients, especially if the condition causing the effusion is inflammatory of origin. Some patient might have cough, but it's typically dry. Remember, this fluid is outside of the lung tissue itself, it's within the pleural space, so the cough is typically dry. So you won't have, there's no communication of the fluid with the bronchial tree, so it's a dry cough. If it is productive, then it's probably from the underlying condition. So for instance, somebody who has pneumonia and has pneumonic effusion, the productive cough is coming from the pneumonia, not necessarily from the effusion itself. And then, of course, you have symptoms of the underlying condition. So, for instance, if it's pneumonia, again, of course, you have fever and malignancies. They might have other symptoms, and they will look at things and suggestive of the underlying condition itself. If it is symptoms of left-sided heart failure, they'll have other symptoms as well. So, for instance, somebody has left-sided heart failure with your pleural effusion, they'll have other symptoms suggestive of left-sided heart failure, and not just the common ones that we've mentioned here. So, for instance, autopnea, PND, these are all things that this patient might have, and that might suggest that the person has heart failure. When you examine these patients, typically there's asymmetric chest expansion, and in this patient, for instance, when you examine, you realize that the chest expansion on the left will be diminished, will be significantly reduced compared to that of the right. So there's asymmetric chest movement when you just even observe, and when you objectively examine the patient to check for the chest expansion, it will be reduced on the left compared to the right. Tactile fremitus will also be reduced on that same site because of the fluid accumulation. Breath sound to be absent, completely absent, or sometimes even if it's present, it's faint. You might hear pleural rap, for instance, and the percussion node will be down. So stony down percussion node, and these are all clinical signs, examination findings suggestive of effusion or fluid. How do you manage this patient in particular? So remember that we have a module where we dedicate solely for pleural effusion, and we go into details of all the clinical features, investigations, and causes of pleural effusion. This is more of a recap of the things that are specific to this particular case. So how do you manage this particular patient? First, you need to get a diagnosis right. So for instance, the diagnosis, let's say you are, so if you are in an exam and the diagnosis alone is 2 marks and you just said pleural effusion, you probably get like 0.5 of that mark. You will not get all the marks. If you just said you add that as left pleural effusion, because you need to be specific here, left pleural effusion, you probably get like maybe 0.75 or maybe 1. You add that is massive, then you are describing. You want to be able to describe this diagnosis to be as descriptive as possible. So it's massive left pleural effusion. Okay, that sounds more correct, but it's still not complete. That will probably get you like 1.5 of the 2. Then you add that it is metastatic breast CA complicated by the massive left pleural effusion. Now, this is a more complete capture of the diagnosis. There's a reason why the breast cancer diagnosis was put in the stem of the question, because it's relevant. And so this question, you might get it either as an OSCE question in surgery, or it could just be in an MCQ question somewhere and they're asking for you to give a complete diagnosis, or you get in a Viva station. So they want you to be complete as possible in your diagnosis. So the correct diagnosis here is metastatic breast CA complicated by your massive left pleural effusion. And the emphasis here is that it is a metastatic breast CA. And so the management of this patient is slightly different from somebody with pleural effusion from heart failure. They are not necessarily the same. It's pleural effusion, but the underlying etiology and pathophysiology is different. So the management will be slightly different. In this patient who we said came to the emergency department with shortness of breath, so this is an emergency case. If you are in a district or you are in a facility where you can pass a chest tube, you can just do a therapeutic thoracentesis to relieve some of the fluid, allow the lungs to expand at that side, and allow the person to breathe, and then get the person to a facility where they can pass a chest tube. So you need to pass a chest tube because this fluid is a lot and you need to drain it to allow for the lung to re-expand. So a chest tube insertion, so a chest tube with underwater seal. So you pass a chest tube with a chest tube with underwater seal, and that will allow allow you to drain the fluids and allow the lungs to re-expand. But it doesn't end there, because we know why this person is having the pleural effusion. There is mets of the cancer to the pleura, and that is causing the effusion. So if that met is still going to be there, this is more of an advanced breast CA, and we know that if you don't close that space, the cancer is still going to be there and the fluid will still keep coming. So the definitive diagnosis, once you drain that fluid, is to close the space, so to close the pleural space, and that is called pleurodesis, and that can be done either using a chemical method or a surgical method. Now, the chemical method, one of the chemicals that is commonly used is talc. Talc is more like some powder that is used. It is instilled into the pleural space, and because it's a chemical, it causes this irritation of the pleural tissue and leads to inflammation. So you have this inflammatory reaction, and the body, in reaction to the inflammation, leads to form these fibrinous tissues in the pleural space, and that obliterates the pleural space. So you have this fibrinous tissue that is formed between the parietal and the visceral pleura and obliterate the pleural space altogether. And so now once you don't have pleural space, then you can't have pleural effusion, and that kind of solves that complication of the breast CA. But remember, the underlying condition is breast CA, and that needs to be dealt with. But in this case, we know it's advanced and probably going to be some form of palliative treatment and all of that. But yeah, so that is how you manage this particular patient. This question was discussed in a way of an MCQ, but it could be rephrased and be given to you as an OSCE question with all the imagings and all these things. And these are some of the follow-up questions that you could be asked in that OSCE question. as I said, we have a dedicated model on playwright fusion. Do make sure to check it out and get more information on playwright fusion, the various types, the pathophysiology. We talk about the management and all of those things, all the information you need to know about playwright fusion. Do make sure to watch it. Yeah, so I hope this was helpful, and see you in the next section.